So really, if I could just say, the purpose of this event, this meeting this afternoon, is for the first time for you to put formally on record what you want us to hear and what you want to say. We have had informal meetings, but this is now a much more formal occasion. However, I want to say that it's not like a parliamentary select committee, which is very robust. This is much more like a conversation, and we really want to hear from you. Of course, we've had these informal meetings, and now we're into oral hearings, and these oral hearings are actually being recorded, and they will go on the website, so everybody, patient groups, know what other patient groups have been saying, and so on. Yeah. So I would like to thank you very much for all the work that you've been doing in the past, and to suggest that, first of all, if you could just say who you are. We know who you are, but it's good for our recording, so people realise what this particular session is about. So I understand, Janet, you're going to start. Is that right?
We've had a bit of a swap, and Emma's actually going to start the reading today.
Emma's going to start.
Yeah.
Okay. Well, I think if you could just introduce yourselves, and I don't mind how you do that, but very free to say it. And of course, Warren, perhaps you could introduce yourselves as well. So it's over to you, how you want to play it. It's your session.
Okay. I'm Emma Murphy. I'm mum to 5 affected children by valproate, and I'm from the Independent Fetal Convulsant Trust.
I'm Janet Williams. I've got 2 adult boys affected. Again, CEO of the Independent Fetal and Convulsant Trust and FACSA.
I'm Warren Matthews. I'm a father of 3 beautiful daughters, 17, 12 and 8, and I'm going to be giving evidence about a father's perspective.
Right. And could I ask you to speak up a little bit, because this room's a bit echoey.
Okay.
Right.
Okay. Firstly, I would like to take you back to the thalidomide disaster of the 60s, remembering the reason why the Medicines Act of 1968 was first put into practice. Due to its horrific damages, thalidomide will always be remembered as the world's worst medical disaster, receiving compensation most deserved in 1973. The same year, sodium valproate received its full licence after a 12-month period in epilepsy clinics within the UK. However, the lessons which should have been learned from thalidomide clearly hadn't, with evidence shown in INFACT's core bundle already presented to the review team. Through archived documents, we know that the drug company requiring a licence for sodium valproate reported their findings to the Committee for the Safety of Medicines in 1972-3, that the drug has shown to be teratogenic, but with no further clinical trials required. The drug was issued its full licence in 1973 with a statement in the CSM minutes of meetings from the 18th of July 1973, which read, "The subcommittee believed, however, that the character of the evidence was strong enough for an assurance to be given to the main committee on the account, but accepted the point regarding anxiety. Nevertheless, they thought it would be best if prescribers were all made aware of the nature of the evidence, and recommended that a statement similar to that proposed by ICI could be included in all the relevant data sheets, but not on packaging inserts, so that there would be no danger of the patients themselves seeing it." We know this paternalistic way in which it was dealt with was accepted in the 60s and 70s. However, there was no attempt to change this approach in the years following, with no actual warnings from the drug company on their patient information leaflets until the introduction of litigation in the year 2000. The problem with the patient information leaflet is that most pharmacists use the white chemist box due to there being 100 tablets in the Sanofi box, and so the majority of women never received a pill with their valproate. Due to the CSM instructing doctors not to tell their patients of the dangers of valproate in pregnancy, this has continued through the years with no new instructions from the CSM or the MHRA for them to do otherwise until the mandatory regulations were introduced in April this year. However, new information for the product licence for Epilin noted information given by the Committee for the Safety of Medicines and stated from the main committee March 1974. On the evidence before them, the committee advised variation of the product licence to delete the requirement regarding monitoring condition that the indication for use reads as follows: for use in generalised focal or other epilepsy. In women of childbearing age, it should only be used in severe cases or those resistant to other treatment. It is important to note that this information given in 1974 is that which was given as new warnings in the valproate toolkit released in 2016. It is yet again vitally important to note that should this information have been used by doctors when first given to the committee in 1974, it would have saved hundreds of lives and thousands of children experiencing catastrophic damages. Due to the failure of legal action against the doctors in 2003 and government's awareness of the instruction of the CSM in 1973 and the following failure of legal action against Sanofi in 2010, again with government's awareness that the drug company had informed the CSM of the teratogenic effects in 1973, INFACT was set up to run a parliamentary campaign for justice. We began in 2012 with MP meetings which brought awareness of valproate syndrome into view, albeit at the time INFACT were not aware of the archive documents. In 2013 we had media attention through BBC Inside Out London and Panorama, which brought the damages caused by valproate to the forefront, and with our first meeting with the MHRA taking place soon after in August that year, 2013. Our discussions with the MHRA continued and resulted in a review on the warnings by the European Medicines Commission, which began 12 months later in 2014. In January 2015, INFACT discovered the archive documents stating that governing bodies were aware of the teratogenic dangers and had been since 1973. Due to our involvement with the MHRA and support from MPs, our then chair of the APPG for AEDs in pregnancy, Teresa Pearce MP, raised the issue in a Prime Minister's question on the 24th of June 2015, and we soon followed by a meeting with the Health Minister Jeremy Hunt and Minister for Life Sciences George Freeman, with the meeting attended by the MHRA and Department of Health. The MHRA claimed that doctors had been told to use their own discretion when discussing valproate with women. However, when we produced the archive documents stating otherwise, the tone of the meeting changed, with a promise from the Minister George Freeman to ensure changes took place, with a statement that this would not continue on my watch. At that meeting, it was discussed with Minister George Freeman that there were 28,000 women of childbearing age prescribed valproate, and figures from the Office of National Statistics showed that around 0.08% of those prescribed valproate becoming pregnant. This means around 336 were exposed in one calendar year, and that 40% of those were actually affected, meaning around 134 children are affected every year. Bearing in mind the drug has been on the market for 45 years, this means there may be as many as 6,000 to 7,000 affected. With the EMA review at its end, 2016, the new valproate toolkit was introduced, intending to encourage doctors to warn women of the dangers of valproate in pregnancy. INFACT had continuously stressed at the time that it was felt that doctors would fail to do so without it becoming a mandatory action, something which the MHRA and Pharmacovigilance Director Dr. June Rain was adamant would never happen. The new toolkit was watched closely by INFACT, only to find that doctors were failing to inform women of the new warnings and pharmacists failing to give out the new patient information leaflet in the white chemist boxes. Following an INFACT survey, media attention and a backbench business debate in October 2017, the MHRA, along with Lord O'Shaughnessy, set a meeting with our APPG chair, Norman Lamb, and informed us that the new warnings were to become mandatory to ensure women received the advice required if they were to continue taking the drug during their childbearing years.
Since this came into action in April 2018, we continue to experience problems with it, and still pharmacists failing to give the warnings, to put the new stickers on the white boxes, and to give the pharmacy cards to the female patients. INFACT, following another survey, met with the MHRA to discuss this, who have now passed on the matter to the enforcement agency and who are working with us at present. As you're also aware, in May this year, INFACT were asked by the Health Minister to respond to the Department of Health's remit, and for us to explain why we felt the government had to take action. The remit read, to build an evidence case for exceptional treatment by outlining the specific needs of both children and adults affected by sodium valproate and their subsequent care needs, and how they are different to those who suffer from mental and physical disabilities but are not affected by valproate. The case should also include evidence and information on the clinical, regulatory and commercial benefits and any evidence of negligence or clinical malpractice, taking into account the existing evidence and standards at that time. In order for INFACT to respond in full to the Minister's remit, we put together a 300-page document as core evidence and required legal representation to do so. We therefore approached, and a report was put forward by Chambers which supported INFACT's evidence. 6 months on, and INFACT still have not received a response to that remit from the Health Minister and the Department of Health. INFACT of an ongoing national database where women can complete a form with their details if they have used valproate in pregnancy and have an affected child, whether diagnosed or not. At present, we have around 2,000 on the database who have been affected physically and or mentally by valproate, the majority of which have neurodevelopmental disorders and are on the autistic spectrum, with poor speech, memory and understanding. A large number of these children are now over the age of 20 and continue to require a huge amount of support from their parents. The excessive stress these valproate sufferers experience to understand the outside world and the circumstances of their actions in many cases has caused mental problems such as anxiety and depression and seizures. This in turn puts an enormous amount of pressure and stress onto the parents, especially the fathers, with them having to give up work to take care of the children and their wife due to her epilepsy and a vast amount of seizures brought on through the stress. We have Dad Warren with us today, who will give it from the father's perspective. Due to the family situation and both parents unable to work, we are aware that neither of them will receive a pension when reaching retirement age, and so are likely to require support from the state for the rest of their lives too. As parents, we continue to watch our children suffer, no matter what age, with the majority of suffering from birth with a major malformation and neurodevelopmental problems, and carrying this burden with them throughout education. Many families have had to continuously fight for diagnosis, for medical and health support and treatments. Many endure countless hospital appointments which can be changed at the drop of a hat by the authorities when an autistic child is set and prepared for it. The majority requires endless GP appointments due to recurrent infections and for support from social services. Many of those affected by valproate find it hard to cope at home, struggling with noise, especially that from other siblings, sound, smells due to hypersensitivity, and the older affected people unable to learn a life skill and live alone without ongoing support. So I come to the conclusion. Through new research, paper released only this week, we are now aware that the amount of valproate taken by mum during pregnancy does not conclude if her child will be affected or not. Instead, the findings show that any amount of valproate in pregnancy will affect the child, causing brain injury. This new paper, written by Dr. Bromley and others, states individuals with fetal valproate syndrome who present with characteristics facial presentation should be considered at high risk of difficulties regardless of the dose of valproate exposure or the presence of a major malformation. Due to this, our latest work with Dr. Bromley and Professor Jill Clayton-Smith, we await the new diagnostic criteria for valproate exposed children, which encompasses autism and reclassified fetal valproate spectrum disorder. Over the years, there have been so many children who have suffered as a result of systematic failure. This is the opportunity to put things right and to help those harmed by valproate, ensuring near normal life. This will not be achievable through clinics, diagnosis or medical intervention alone, but by allowing them and their families supporting them the lifelong financial help they require. For the majority of families living on council estates where they endure violence and bullying, and those living in private lets where their parents are at constant alert that their tenancy agreement could be ended at any time, they remain most vulnerable and feel life is unsafe for their children. The time has come where we have to stop these families from suffering at the cost of government's hidden truths about valproate and the drug company continuously making hundreds of millions every year on the back of it. It's time to change cultures and behaviours towards those disabled by this drug and to ensure they have the opportunity to live a life where they are able to own their own home and are not discriminated against through the system simply because the government refused to tell their parents the drug would be poisonous for them while in the womb. In 2016, the Minister for Life Sciences, George Freeman, in a letter stated, "If it happens that there are lessons from the department's historic handling of this, I will of course be happy to consider a statement of regret if appropriate." So during your summing up, we ask you to consider the above. And many children affected, those especially who are now in their 20s, 30s and 40s, and the amount of pain and suffering they and their families have endured as a result of devastating effects of this medication. Let's also remember the many families who have experienced loss as a result of valproate in pregnancy. The death of a child is unbearable as for any family, so it is important you consider them too. When making your recommendations, we ask you to consider a guaranteed future for children affected, ensuring diagnosis for their education purposes, that present geneticists train the new generation to ensure diagnosis and the constant knowledge of fetal valproate syndrome, for future planning to make it easier to replicate guidelines to forge a pathway for other AEDs in pregnancy, that a respectable care plan is offered to those affected to support them through their lifetime, allowing them a mortgage and a sustainable life, that families experiencing bereavement due to valproate exposure receive a posthumous payment, and that the benefit system recognises fetal valproate syndrome for benefits such as employment and support and PIP, awarding the funding for life in these circumstances, and that the funding to allow the forming of a diagnostic clinic is ring-fenced so as to stop any future government from withdrawal.
Thank you very, very much indeed. That was very clear. Can I just ask you, you clearly have gone through all this very often with enormous thoroughness, and you've done the remit, you've told us what you want, and thinking all about that, what do you think is really the most important thing that you feel that we should be recommending out of all this that you've been through, that you've seen, that you now have experienced and in the past, but is there anything in particular that really shines through if only the review would really concentrate on this area? Or is it just too complex for that?
No, I mean, for us in particular, the main area is to make sure that not just the children affected, but the families are ensured that they can afford to live how they need to live. We know that bringing up a disabled child costs more. We know that a lot of these children, when they reach adult age, are unable to work. The majority of them will be on benefits the rest of their life, as will the parents who have been unable to work and not have a pension behind them. So for them to make sure there's financial stability has got to be first and foremost, I think.
Well, that's very helpful. Yes, thank you for that. You talk about trying to change the culture within society, really, towards these children, and presumably to the adults, the families as well. How on earth are we going to even think about that? How are we going to do that? I mean, it's a huge task, isn't it?
Well, for us, I mean, that's something that's already working on at present with the work we've been doing with the MHRA, changing the way that doctors think as far as warning women about the medication when they're prescribing it, about the way that pharmacists dispense the medication, to making sure there's warnings on the boxes. But I also think it's important for it to be recognised within schools, like Down syndrome would, like autism itself would. And I think that's the sort of structure that we need to be going through now to make sure that the health system and the education system do recognise this condition.
And finally, a question from me, and then I'll pass it to my colleagues. Numbers are a real problem in this area, aren't they?
That, yeah.
Have you got any clarity now on the numbers that you think we should be addressing?
Well, it's like I've stated in here. I mean, we did discuss this previous with the MHRA as well, and we know that going off the figures that we worked out with the MHRA and with it was George Freeman, wasn't it, back in 2015. And they stated that there was round about 135 or something that was affected every year, going off the percentages. So since about, I mean, obviously it's going to fluctuate because of the amount of and the way that this drug has been prescribed over the years. But we reckon there's round about maybe 5, 6, top 7,000 children that will have had a diagnosis and will be affected.
Is that children who are diagnosed at the moment?
No, that's just affected. That's the whole, yeah.
Affected.
So that would include people who haven't yet been diagnosed?
Of course, yeah.
Right. So, questions?
You mentioned, Emma, sort of the figure of 40% of children from mothers taking valproate. That's direct effects. There are two things there which I don't understand. One is, how can you be sure there aren't smaller effects? Because we know it affects general IQ that you wouldn't know about in addition to that. And secondly, there's the effects on the other children in the family and the parents of the tension and the stress that Warren so well described. So the French scheme say they've received 323 for what they call direct victims in utero-exposed children, but they also recognise 764 indirect victims, parents and siblings, who I take to be children in the family and effect on the parents. Do you have any observations on that?
Well, all the research that's been done over the years, and no doubt that will be discussed when the medical professionals come in. Yeah. The 40% comes from research that was done and started by Dr. Brown in 2013. And she stated that there was 40% of these children that had been exposed to valproate had actually got neurodevelopmental disorders, which included autism. So that's where the 40% comes from.
I'm arguing that it may be more, that's the point.
Well, I can only state what the medical profession has told us. Yeah. I mean, we actually know that if a woman gives birth to a first child and that child's affected, then there's a high percentage chance that a second child is also going to be affected too. So when it comes to affecting other siblings, unless that woman has changed her medication in any way in between, it's quite possible that if the first one is affected, then the second one will be also.
Thank you.
Can I then ask you, clearly women who are epileptic and take this drug because they feel it's certainly helping them in their epilepsy, and that's absolutely understandable. And then they're pregnant, and then they have a child, and the child is disabled. And then you've just said that also there's a likelihood the second child will be disabled. So is there no sort of research done on the first child to ensure that this could have been the cause?
Well, we know there's been a lot of research over the years on this, and of course if Professor Joe Clayton is here later on, no doubt she'll be able to explain this to you about all the research. We know for a fact that this is, valproate does cause this particular syndrome and these problems to varying degrees. So I mean, obviously there's been a huge amount of research done on this, and we know that the drug company itself, back in 72, 73, there was a clinical trial on epilepsy for 12 months before it had its full licence, and they actually stated that the drug was found to be tetragenic anyway. So we've known this from a very, very early age, very, very early on.
So was the case that this drug was still in the woman's blood system or whatever?
Yeah.
And so it wasn't necessarily that she took more pills, it was there anyhow. Are you saying that? Or are you saying you need more pills in order to... I'm thinking of the second and the third and the fourth.
I mean, to be honest, I mean, in my situation, for example, I was on 1,200 milligrams with both boys. Yet we've got women that have come to us where the drug doses has changed, but the children have still got the same problems. So it seems to be, and again, I can't quote this, you know, medically, but it seems to be, from our perspective, that it also depends on the woman's metabolism and how quick that drug gets into her system as to how badly it affects that child.
How old are children when they're usually diagnosed? What's your average sort of diagnosis?
Well, again, that's something that varies. We have children that's been diagnosed at birth because of the facial features. Then we've got children that have gone on to be 6, 7, maybe 8 and shown the autistic spectrum disorders and received the diagnosis.
So you wouldn't
at that point
necessarily know between your first child and your second child that you thought,
in some cases probably not.
if
no.
your first child had been affected. I mean, sometimes you would, but sometimes you wouldn't. Is that right?
Mm-hmm.
I think as well for a new parent with a new child, they don't know nothing, you know, and obviously, you know, children progress at different speeds. I mean, I know for ours, they all walked different times, spoke at different times. So it's you know, same between the first and the second. It's a hard thing to try and gauge because you're new parents. This is, you know, it's a new experience, isn't it? So.
Can I just ask about current prescribing practices? So, and do correct me if I'm wrong, but my understanding is there's an intention now to change pack sizes, so we don't have this issue between, you know, the original pack and the white box and the labelling and so on. What's your thinking on that? So when that gets implemented, let's not say if, let's say when it gets implemented, because that's what we're all expecting, does that reduce or completely remove the risks that you're most concerned about, or is further action needed?
Well, we hope that will really bring the numbers down, because at the moment it seems to be the biggest problem is with the white chemist box. So we're hoping with the smaller purple ethylene boxes, obviously that will then take that out of the equation. So yeah, hoping that will help tremendously.
But that should
hopefully, yes,
stop the risk of future exposure, provided people act on the patient information. Well, you can't guarantee
that. I mean, obviously, if people take that information and act on that information, then hopefully yes.
Yeah, provided they act.
Yes, I was going to ask you the question. I mean, I've been actively campaigning for such a long time, and you've learned invaluable lessons about what happened with valproate. There is the next generation of drugs that are coming out, Keppra. I never pronounce the full name. But if you were to say now, well, what should they be doing that maybe they're not doing as a result of the lessons you've learned, so this doesn't happen again?
We have brought this up with the MHRA because I now have a child affected by Keppra, devastatingly. And we have brought this up because it is an issue. And they have said that they are at present not going to act on it till EPILIM has been resolved. And I find that an insult. I find it an insult to the women, and I find it an insult to the children who, we know all epilepsy medicines are harming children, and I think it is a disgrace for the MHRA to not be learning now as we are here working on EPILIM. It's a disgrace that they're not working on the other medications.
We know that the other medications do have warnings in the patient's information leaflets. 9 times out of 10 those leaflets are that big that a lot of people don't pay much attention to them, unfortunately. So for doctors to be giving women of other medications an informed choice, like they would with other things that are other things that are prescribed. You know, you usually pick a medication up from the pharmacist will ask you. So why they can't do that with the other medications? When we started this campaign, all we wanted was women to receive an informed choice. We didn't necessarily ask for the pregnancy prevention ban and for it to be banned as such. So for women on other AEDs, just to receive that informed choice and to be told that that would be a possibility, really would be a good place to start.
And it's currently not happening. We have women contact us every single day. The newer ladies being switched from EPILIM to now Keppra are coming, and they're just not being told of the dangers. And that's what we mean when we speak of there needs to be a culture change. Behaviours need to change because these medicines, they're teratogenic and they're harming babies. We can't move forward and another 10 years have a Keppra epidemic of this. We've got to learn from this and stop this, and hopefully the work that we have done, it will make it easier to implement changes with the other medicines. And also, we've campaigned for 6 years. It's taken 6 years to get these warnings in.
Do we have the same white box problem with Keppra?
With all of them.
So having got to the point where you're getting smaller pack sizes now,
Yes.
we're still left with Keppra coming in white boxes.
Yeah,
So that patient information leaflet.
Well, all the medications, they all differ as to how many's in the actual box. So for there to be, say, 28 in a box, then you've got the month covered. If the woman just takes the one a day.
Have you discussed in your discussions with MHRA, have you talked about a sort of pan-AED approach as opposed to just an EPILIM approach to pack sizes? So
that has been mentioned.
Yeah.
That has been mentioned.
What's their position?
But again, like they said, they want to deal with valproate first before they move on. But I think we need to be sort of stepping up a little bit with other AEDs before that even happens. We need to be looking at making sure women get the patient information leaflets, get the warnings, get the alert, the prompt, if you like, just to give them that informed choice that it is a possibility. You can't always guarantee that that's going to happen. You know, we do have 1 or 2 ladies that have come to us whose child hasn't been affected, which is brilliant. So I mean, obviously, it is quite possible that could be the case with the other medications, but I think an informed choice of some description, needs to be there.
But as you said, it's not just the patient information leaflet, is it?
No.
Because you're right, not everyone reads that, and that's not.
Well, this is it.
There needs to be a culture change within healthcare professionals because women are asking the questions. They are purposely making appointments to ask these questions, and doctors just state that these medicines are okay. They control your epilepsy.
In one meeting in particular with the MHRA, there was a person there from NHS Digital, and he actually turned around to us and said that the doctors in some circumstances are not giving these warnings verbally because the warning comes up on the screen, and he called it prompt fatigue. So the warning will come up and I haven't got time for that, hit the button, it'll go away. So the warnings are not going across because of this prompt fatigue, and that's the culture that needs to stop within the NHS, because these women, no matter what medication they're on, need that informed choice and need to be pre-warned.
And pharmacists should be doing the same.
Of course they should, yeah.
Can I ask about epilepsy? So, on the whole, we hear a lot about Epilin and sodium valproate.
Yeah.
Are there other medications that are equally effective to prevent seizures to help women who are epileptic?
Everybody's different. So just because it suits one person doesn't mean to say it's going to suit another. Epilin didn't work for me, but it worked brilliantly for Emma. And I would imagine it's going to be the same with other medications. Personally, I've tried about 8 different medications along the way, different combinations, and the medication I'm on now is the best I've ever been. And it's took me all that time to find it. So obviously, there's going to be other drugs out there that will be suitable.
And do we know if those other medications have the same impact on pregnant women?
We do know they are teratogenic, not to the degree that Epilin is.
I see.
And that's the huge worry.
Yeah. Great. Well, other things, I don't know if anybody wants any other questions.
Just one more from me actually. It's just about not the numbers so much, because we're now talking about what we think the best estimates are, when it's effective. But how are we going to reach them? If the issue is about getting the support and care packages people need, how are we going to find those who have yet to surface? What's the pragmatic way of doing it?
This has been an issue, and when we first started this campaign, maybe it was me being naive, but we asked for a public health conference to be held, that the Minister, Jeremy Hunt at the time, would hold a press conference and alert ladies to this, because it needed to be in the public domain. And since then we have struggled with media to get it out in the public domain. I think for this there needs to be a public press conference.
There needs to be something out there if we need to bring these ladies forward for them to be aware. If we're looking at reaching the women that need the help for the children, there definitely needs to be some sort of awareness campaign. Isn't the right, I don't know the right terminology for it, but there definitely needs to be something. I mean, we've done media, newspapers and TV, but that's not going to doesn't reach people. So
we thought when we'd done Panorama, we thought we would bring these ladies. It just didn't, and it's so disappointing that we can't reach these ladies. They need help.
And a lot of the time, I think the sad thing about it is some of the women tend to be, I don't know, that's not the word, don't want to sort of accept the fact that the problems that their child has been caused through them taking the drugs. We've all gone through the guilt trip, and believe me, it's not nice, and so some ladies don't really want to accept that this has been caused by the drugs.
Could I just ask about, just on this point of how do we find everyone else who hasn't yet been identified or had a diagnosis or joined groups like yours? We would try to work out whether it's feasible to seek the help of GPs in this, because the GP's medical record of all their entire list should give them the opportunity to say, well, I know how many women I've got on my list, I know how many women who are diagnosed epileptic I've got on my list, I know how many women who are diagnosed epileptic and taking valproate or have taken valproate are on my list. Isn't that part of the way forward in terms of finding the people who haven't yet surfaced?
Possibly, yeah.
Maybe not an audit. Some kind of audit.
Well, it's like everything else with the prompt fatigue. The GPs are really dealing with a lot at the moment, a lot of other issues as well, and to put that onus onto them as well as everything else, I don't know how we go about doing that. I mean, obviously, they probably would be the best people to reach these ladies, definitely.
But if we're struggling now with the warnings, it's going to be hard to find these ladies.
Plus, I guess you are going back up to 40 years. You are going back sometimes to paper records.
Yeah.
It's not going to be a straightforward search.
Right, are there any questions you'd like to ask us? We want to keep in contact with you. This isn't just a one-off. So, as we've said to other patient groups, please come back to us if you want further information.
We haven't really got any questions. We've got a copy of the oral submission here for you if you want to take that with you.
That would be very helpful.
We've got some ideas as to maybe how things could be done. We put information in here as to how these figures have been reached and where they've come from, so it may give an idea as to the follow-up to what we've said.
All right.
Okay.
Well, thank you so much, and thank you for all you do.
No,
When you're out of
as
this
well.
room, supporting other women and their children. And thank you, Warren, for coming and telling us about your work. Thank you very much.
Thank you.